How to help your asthma patient select the best inhaler device whilst weighing up all the important factors. Is it the right drug, cost, ease of use? Am I sure how to use it myself? And importantly, environmental impact. I'm Alex Wilkinson, respiratory consultant in Hertfordshire, and in this short presentation I'm going to try and help you with this important question. The information and QI projects here are aimed particularly at adults and children over 12, but at all ages inhaler technique errors are extremely common, so it's vital to understand inhaler technique, how to assess and teach it to ensure you get the right inhaler device for your patients. Commonly used types of asthma inhalers are metered dose inhalers, MDIs, which spray the medicine out when you press the button, and dry powder inhalers, DPIs, which release the medicine when you inhale. We learned in the other video on disease control how the spray inhalers, particularly the blue salbutamol sprays, dominate treatment of asthma in the UK, but they're not the most effective way to control the disease. It's important to understand the difference between these two types of device. One of the most important differences between DPIs and MDIs is the different technique they require. Metered dose inhalers, or MDIs, have a pressurized can that sprays the medicine out when you press the canister, and dry powder inhalers, or DPIs, rely on the patient to breathe in hard and fast to get the medicine out of the device. The different devices each have their own pros and cons. MDIs require slow and steady inhalation over 3 to 5 seconds. They require the patient to be able to reliably press on the canister at the same time as breathing in, although for some drugs, breath-actuated devices are available that spray the medicines out for you during inhalation. Dry powder inhalers, by contrast, require a fast and deep inhalation within 2 to 3 seconds. They are good for people with normal inspiratory flow. MDIs may be best for patients with poor inspiratory flow, very young or some very old patients, particularly older females, and in these circumstances the MDI should be used with a spacer wherever possible to improve drug delivery. MDIs and spacers typically require cleaning, whilst with DPIs there's no need to clean the device or to use a spacer, and that may be more convenient for patients. MDIs sometimes don't come with a dose counter, making it hard to keep track of the doses or know if your inhaler has run out, whilst DPIs always come with dose counters. And finally, although it's very important for some patients, MDIs contain powerful greenhouse gases. Their carbon footprint is about 10 to 37 kilos per device, whilst DPIs have a small carbon footprint, less than 1 kilo per device or month of use. Here is the suggested strategy to choose an inhaler device. This diagram is the second half of a downloadable one-page visual aid to support asthma reviews. Start by asking the patient to show me how you use your inhaler. If a patient has an inhaler already, it's incredibly useful to watch them use it and can sometimes reveal some surprising mistakes. Breathing in fast and deep through an MDI is very common, and it can be hard to correct this natural tendency even with training. For these patients, breathing in too fast means more of the drug lands in the throat rather than the airways. Equally, some patients struggle to press the canister or to coordinate pressing and breathing in effectively. This is particularly true for those who naturally breathe in hard and fast through the inhaler. These patients would likely do better with a DPI. For patients who need an MDI but struggle to coordinate pressing and breathing, a breath-actuated MDI may be a better option. If patients are using an MDI effectively, consider if they would prefer a device with a dose counter. Not all MDIs come with a dose counter, and it can be difficult to know how much medicine is left. One cannot know from shaking an inhaler, and propellant may be sprayed out even after the medicine has run out, and unreliable dosing occurs. The lack of a dose counter can also result in patients discarding MDIs that are still half full. For patients using an MDI, for whom there are no clinical indications to move to a DPI, we can still ask if they're interested in a more environmentally friendly inhaler. For the patients who need or prefer to use an MDI, encourage them to use a spacer and consider whether changing brand or changing dosing regime could reduce the carbon footprint of their care. In reality, most patients can be trained to use most devices. So patients can usually be offered a choice of which device they prefer, and most would prefer a more environmentally friendly inhaler. Which inhalers are we currently choosing? We learned earlier about the drugs we are currently using to treat asthma and the widespread over-reliance on reliever MDIs and underuse of controller inhalers. This graph looks at how the types of inhaler device we use has changed over the last 20 years or so in the UK. In the year 2000, over 70% of combination inhalers, about 2/3 of steroid inhalers, and 40% of blue reliever inhalers were dry powder inhalers. Over the subsequent 2 decades, there's been a really dramatic switch to MDIs for reliever and steroid inhalers. I think this is largely driven by cost, as inhaled corticosteroid, ICS, and short-acting beta agonist, or SABA reliever inhalers have historically been cheaper in MDI form. These figures haven't really changed in the subsequent years since this graph was made, and what this means is that about 2/3 of UK asthma patients have a treatment regimen that's over-reliant on SABA, and the vast majority of this SABA is PMDI. This is not good for patient care or for the environment. What sort of device do patients prefer? Here's the biggest recent study and the only non-industry sponsored study in which patients were offered a wide choice of different devices to use, were trained to use them, and then asked, which device would you prefer for everyday use? Although there was no clear single standout device winner, multi-dose dry powder inhalers were favoured more often than the other inhaler devices. However, the study included no questions on the environmental impact of inhalers, which I think is increasingly important to patients, although most patients are unaware of the large carbon footprint of MDIs. At the ERS Congress in 2021, we heard evidence from over 12,000 asthma patients, and most, 60%, would change inhalers for environmental reasons, and a further 21% said they might. So there is also appetite among asthma patients to consider a different and equally effective device for environmental reasons. Often in the clinic, you can spend some time going through the options with the patients, and they come back with a question, yeah, doc, but which one's best? I think this is an entirely reasonable question for a non-expert to ask, and my approach would always be to recommend a DPI in these circumstances if the patient can use it. They have great real-world evidence in terms of efficacy. In carefully controlled RCTs, there's no difference between MDIs and DPIs, but in these studies, patients are always very well trained and motivated. Multiple real-world studies show that most asthma patients do better on DPIs. DPIs have the lowest carbon footprint, which is an important priority for greener NHS. And finally, DPIs are often preferred by patients. Whichever device you choose, it's vital to know how to use it so you can teach and assess the patient effectively. And this is where there's an elephant in the room. Most healthcare professionals don't know how to assess or train inhaler technique correctly. If that's you, then the Asthma UK website is a great place to start with lots of great resources and educational videos. Very briefly, what are the key steps? Firstly, prepare the device. This may be shaking the inhaler or loading the dose of a DPI. Many DPIs need to be held upright when loading, so bear this in mind. Breathe out fully and lift your chin, which is important to straighten the airway and help the medicine down into the airways. Breathe in at an appropriate speed through the inhaler, slow and steady over 3 to 5 seconds for an MDI, and fast and deep with a DPI. Insufficient inspiratory effort is the most important error with DPIs, and coordination is the most common error with MDIs. Hold your breath for at least 3 seconds. And finally, take the second dose. Another common problem with MDIs is either they double puff during one inhalation or failing to take the second puff at all. For MDIs, you should wait 30 to 60 seconds between puffs, and ideally, they should be used with a spacer as well. It's not enough just to demonstrate technique or share a video. You have to assess and reassess at every opportunity because inhaler technique deteriorates over time. This is particularly true for those patients who lack motivation, who have poor disease control, and for those patients using an MDI. Whistles in placebo inhalers can be very useful for assessing inhaler technique, particularly if you have to use a remote consultation. Some manufacturers provide free inhalation whistles so you can assess and train proper technique, and they only whistle if you have the correct inspiratory flow. Similarly, for MDIs, there's a tray inhaler whistle that's very useful in clinic and for video demonstrations of inhaler technique. It contains no propellant but makes a realistic swoosh noise when you press the button and has infinite doses. And if I breathe in at the right speed, it will whistle as well. MDI placebos provided by manufacturers do contain greenhouse gas propellant, but really there's becoming less of an excuse for using them. The patient website asthma.org.uk is also a great resource for directing patients to instructional videos, but they must be used alongside inhaler technique assessments. Here are some more examples of placebo devices, some of which whistle if they're used at the correct technique, but all allow you to see patients practice device use and handling. Some inhalers, like the Nextaler, make a click sound once the patient's generated enough inspiratory force. For MDIs, spacer use should always be encouraged, and they are essential for young children. The InCheck device can be a useful way of assessing which device type is suitable for patients and to coach the correct inhalation technique, but it's also important you see the patient handle a real device. Asthma and Lung UK, as well as the Right Breathe website, have inhaler technique videos that can be sent to patients via SMS or AccuRx messages after a consultation to reinforce correct technique. What about exacerbations? For most asthma patients, DPIs are likely to be as effective during an asthma exacerbation as other delivery methods. Here's a systematic review of 23 studies which suggest that a number of DPIs were as effective as MDIs during an exacerbation. Of course, if patients struggle to use an MDI correctly when they are stable in clinic, they're likely to struggle with coordination even more during the panic of an exacerbation. So I don't think giving everyone a SABA MDI is the right strategy. In Northern European nations such as Sweden and Finland, the majority of reliever medication is via DPI, which should give us confidence that these devices can be effective. Another problem with SABA MDIs in the UK is that they lack dose counters, and patients frequently continue using them when empty or nearly empty, resulting in unreliable dosing. In this review, up to 40% of patients believed they were taking their asthma medication when actually they were activating an empty or nearly empty MDI. But this is not a problem with DPI relievers which have dose counters. Keep in mind, though, that the most important life-saving inhaler in asthma is the one containing a steroid, and it's important to remind patients of this too. The 2024 NICE asthma guidelines advise using combination preventer and reliever inhalers which control the disease at the same time as relieving symptoms and can prevent severe exacerbations. It's not necessary to give all these patients a salbutamol MDI reliever as well. This graph gives a more detailed illustration of the difference in carbon footprint between different inhalers, with MDIs in blue at the top and DPIs and soft mist inhalers in yellow at the bottom. There are also variations in carbon footprint between different MDIs depending on the type and volume of propellant used. So for instance, Flutiform MDI has a much bigger carbon footprint than Foster MDI due to the type of propellant gas used. On the other hand, Ventolin has a far higher carbon footprint than Salamol or Aramir due to the volume of hydrofluorocarbon gas used as propellant. Because Ventolin, Salamol and Aramir are all salbutamol inhalers, all MDIs with the same medicine and device type, this is a change and the only change that could be done safely as a batch switch. There are two device control quality improvement projects available on the website. The first one ensures your team has the information, equipment and resources to assess inhaler technique and support appropriate training. The projects also contain pre-written patient information messages. The second is a carbon footprint reduction project about switching from the brand of salbutamol inhaler from Ventolin to Salamol or Aramir, with patient information to explain the change. So in conclusion, firstly, we need to select the right drug in the right device for the right patient. At the moment, far too often that's the blue MDI reliever, when according to asthma guidelines, it should be a preventer or combination inhaler. Secondly, make sure you can and do teach and assess patients' inhaler technique. It's vital for effective asthma care. Finally, There are many reasons to choose DPIs in appropriate patients, including patient preferences, real-world clinical evidence, and environmental impact. On the Greener website, you'll find step-by-step quality improvement projects that will help you upskill your team with the information, resources, and equipment they need to confidently assess inhaler technique and support appropriate inhaler device choice. The projects also contain pre-written patient information leaflets, messages, and videos. By choosing the right drug and the right device for the right patient, we can make asthma care better, safer, and greener. Thank you.